Thank you. I'm very happy to join you virtually today, and I will talk about how to maintain cognitive function in atrial fibrillation patients. Those are my disclosure. So why is it important? It's important because when you ask a patient, more than half of them would prefer to die than to suffer from dementia. So it's from the patient side a major point in their life. And what we know is that atrial fibrillation is associated with an increased risk of cognitive decline and dementia. Usually there is a 40% increased risk compared to patients in sinus rhythm. We also know that atrial fibrillation is linked with an increased risk of stroke, but also with silent cerebral infarction. So this is one of the hypotheses explaining why atrial fibrillation is linked to cognitive decline. So obviously, we think if we do anticoagulate the patient, he will do better. We have several studies showing that in patients with an indication of oral anticoagulation, there is a 30% lower risk of dementia. So those are the studies. Obviously, all the studies are retrospective. What we don't know is efficacy is similar between VKA and NOACs. So data are conflicting. Studies are retrospective, usually using national database. Several large observational studies in Asian mostly, but also in non-Asian population shows that NOACs had a comparable risk of dementia when compared to VKA. But in other large-scale database studies, NOACs were associated with a lower risk of dementia. So this is something we still don't know. Is it better to use a NOAC compared to VKA for those patients? So there is two studies looking at that. They are small. So the first one is ARISTA, 280 patients, follow-up 24 months. They are comparing apixaban and warfarin, and the primary endpoint is a change in cognitive functions and new cerebral infarcts on MRI. The second one, CAF, 120 patients, follow-up is identical, comparing dabigatran and warfarin, and the primary endpoint, incident dementia. Those patients are older and sicker compared to the first trial. One on the second question is, we know that obviously we have to anticoagulate patient with an indication, but should OACs be extended to low-risk patients to prevent cognitive decline? So we have a case control study published by Gaeta and Jack in 2013, comparing 180 AF patients, mostly low risk, so CHA2DS2-VASc 0 or 1, and 90 control in sinus rhythm. So patients were matched and compared to level on education, depression, and all comorbidities. And they show an increased risk of silent cerebral infarct on the MRI and lower cognitive performance in patients with atrial fibrillation compared to a patient in sinus rhythm. And patients with persistent permanent atrial fibrillation had a lower cognitive function compared to patients with paroxysmal atrial fibrillation, but still it's a case control. In a large retrospective study done by Rivard and colleagues, patient with a low CHA2DS2-VASc score, in patients with low CHA2DS2-VASc score, oral anticoagulation was associated with lower risk of dementia, but only in patients older than 65 years of age. So I did present that to the last year. So the BrainAF trial is ongoing in Canada, in almost 40 centers in Canada. So inclusion criteria, patient 30 to 60 years of age with a low risk of stroke. So basically, excluding sex, we have patients with a CHADS VASC 0 or 1 if they have vascular disease. And we're comparing Xarelto 15 to placebo. The primary endpoint is no cognitive decline, defined by a decrease in MoCA score of at least 3 points, stroke or TIA, and TIA we just use in aphasia or motor deficit. So we have more than 900 patients randomized in Canada. The number is around 2,000 patients. It's an event-driven trial, so we are counting the events. And there are several sub-studies ongoing. So we have sub-studies on biomarker, genetic and cerebral MRI. And this year we received major grants from Canadian Institute of Health and some from foundation, so that allow us to increase the number of sites. So we're planning to finalize enrollment within 2 years. So there are other unanswered questions. What is the minimum atrial burden associated with cognitive decline? And so this is a part of the Artesia trial. So in the Artesia trial, we are run by Jeff Healy. MoCA is done in a part of the population. One another question is, should atrial cardiomyopathy be considered as an indication of oral anticoagulation? And we don't know neither the role of left appendage occlusion. And should OACs be continued after successful atrial fibrillation ablation? So this is part also of the Ocean trial with ongoing right now. So they are performing MoCA in patients in this trial. So we should have the answer to those questions. So thank you for your attention.